Prevention Coordinator at the Iowa Department of Public Health. He has a master's in public health from Des Moines University and a BA from Grandview University in health promotions. Andrew lives with his wife, 3 sons, and a dog south of Des Moines. He enjoys spending time with family and friends, running, and being outdoors. Susan Lopez-Payan has extensive experience in marketing communications and has worked in public health with a focus on diabetes prevention and control for over 15 years. As a consultant for the National Association of Chronic Disease Directors, Susan works with state health departments across the country to scale and sustain the National Diabetes Prevention Program and promote diabetes self-management education. She is the former manager of the California Diabetes Program in the State Department of Public Health and served on the board of directors for the Diabetes Coalition of California, as well as chair of NACDD's Diabetes Council. Susan is a former vice president and creative director for an award-winning marketing communications firm and currently leads communications for the NACDD's diabetes team. Susan has a Bachelor's of Arts degrees in the industrial design from California State University, Fresno, and a business certificate from University of California, Davis.
So, as Karen said, I'm with the Department of Public Health. I'm the primary prevention coordinator for diabetes. This is my information there. I'll also go through this PowerPoint. Oh, I need to speak up, sorry. I'll also be going through this PowerPoint in some places at different speeds. So if you need any information from this PowerPoint or from me, feel free to write my contact information down there. Because DPP has been talked about a little bit, I don't want to overdo that because I think a lot of you do know about DPP. So here we go. We're going to recap a little bit on what has been happening since May. In May was the Diabetes Prevention Summit engagement meeting, which the action plan came out of. NDPP, which is National Diabetes Prevention Program, Iowa's landscape, where we're at with prediabetes, and then I'll get into the action plan itself. The May Summit was a diabetes prevention summit that was used to engage stakeholders across the state. Its purpose was to bring diabetes prevention experts together to brainstorm a plan, and out of that plan came the action plan. On day 2 of the summit in May, attendees met in 4 breakout groups. Each of the 4 objectives were awareness, availability, screening, testing, and referral, and coverage. During those breakouts, each group was focused on conversations on how to attack the issues that they were sitting in on those conversations. This is all to reduce the incidence rate of type 2 diabetes. As Katie just presented on the diabetes strategic plan and the action plan, I just wanted to put these 2 things up there because they overlap in all the right ways. 3 of the 4 objectives of each plan are represented there. So I just want to show to you and talk with you that these plans are not doing their own things. They're actually aligned and headed in the same direction. So with the National Diabetes Prevention Program, many of you know this, the National Diabetes Prevention Program, or the NDPP, is a partnership of public and private organizations working to prevent or delay type 2 diabetes. The partners work to make it easier for people with prediabetes to participate in evidence-based, affordable, and high-quality lifestyle change programs to reduce their risk of type 2 diabetes and improve their health. The NDPP provides a framework for diabetes prevention efforts. It brings together partners from the public and private sectors to prevent or delay type 2 diabetes. And the partners include federal agencies, state and local health departments, national and community organizations, employers, public and private insurers, healthcare professionals, university community education programs. The NDPP works to make it easier for people with prediabetes to participate in affordable, high-quality lifestyle change programs. Through the NDPP, partner organizations include delivered the CDC recognized lifestyle change program nationwide. It ensures the quality and adherence to proven standards and trains community organizations that can run a lifestyle change program effectively. A key part of the national DPP program is the lifestyle change program itself to prevent or delay type 2 diabetes. Hundreds of in-person and online lifestyle change programs nationwide are taking place. To ensure high quality, CDC recognized lifestyle change programs meet a certain standard. These standards include following an approved curriculum, facilitation by a trained lifestyle coach, and submitting data each year to show that the program is having an impact. The evidence base behind NDPP was a clinical trial study. It had 3,200 participants, over 3,200 participants, and they were broken up into 3 groups. One was a lifestyle change program, one was a metformin drug group, and one was a placebo. They all received some information on diet and exercise. However, the lifestyle change program received coaching as well in their curriculum. And it was shown that the research showed that people with prediabetes who take part in a structured lifestyle change program can cut their risk of developing type 2 diabetes by over 50%, 58%, and 71% if they're 60 years or older. By simply decreasing their body weight by 5 to 7% and increasing their physical activity time up to 150 minutes a week. The impact of this research had a lasting outcome, and it showed that even 10 years after completing the program, individuals were still 1/3 less likely to develop type 2 diabetes. The basic structure of a DPP is for the first 6 months you go to 16 minimum curriculum courses, and in the second 6 months you go to some maintenance courses that are in a minimum of 6, so once a month there. Some examples of curriculum are strategies of healthy eating, managing stress, and in the second part of the program, preventing relapse, things like that. So within Iowa's landscape, there's approximately 2,396,000 adults in Iowa, and about 35% of them, so over 1/3, have prediabetes. It is estimated that 1/3, but in Iowa we're at 35% approximately. Some information that we pulled out of the BRFS, which is the Behavioral Risk Factor Surveillance System, is in 2013, a question that was asked during that survey was, have you ever been told by a physician or a healthcare provider that you have prediabetes or at a higher risk of getting diabetes? And only 6.2% of people in 2013 said they had. However, like in the last slide, I stated that we know that 35% of people have it. So there's quite a gap. You can see that we have increased a little bit, however, we've leveled off. And this brings concern because there's still approximately 27% of people don't know that they have prediabetes. This is the collection of data from the question, demographics. Some things that stand out are 7.8% of adults have prediabetes, which is low. Individuals 65 to 74 years old are standing out at 13.5%, and individuals with an income of less than $15,000 are standing out as well as 10.3%. So what is concerning about the BRFS data is that diabetes takes a huge burden on those demographics, and a person with diabetes has healthcare costs of 2.3 times more than a person without. And at a national level, $245 billion are being spent on individuals, and that's up 41% in the last 5 years. Oh, that's the next slide. So why is it important to act now? Now I did borrow this slide, and there's the sources there. But basically, having diabetes increases, as well as prediabetes, increases risks for many things: hypertension, heart attack, stroke, and then as well as dying from those conditions. It's not wanting to move forward for me. Okay. So this is a pre-diabetes risk test, and some of you may have seen it. I wanted to put it up here. It's 1 minute long. There's 6 questions, so you have to focus on the questions as well as the cute hedgehogs, because I'm just going to play it once. So follow along with the hedgehogs in the background here. I'm going to hopefully play this. So there's also there's a puppy one. There's just a room full of puppies. So if you have to watch it twice sometimes, where you go back and get the information. All right. Oh, so smart. Did I come over here? Nope. There we go. Thank you. Okay, so in Iowa in 2015, we had 4 DPPs that were being implemented across the state. And now, currently, we have 40 DPPs, and I overlap this, well, I didn't overlap this, you may, our epidemiologists overlap this, with the prevalence rate by percent. So the 7.8% is the number of adults in Iowa that have prediabetes, been confirmed. So you can take a look throughout your counties by the shade of color there, which counties might have a higher rate. So. This real quick is a lot of information. These are all the DPPs, so if you need this information, it's also on that table over there, the resource table, and I'd be more than happy to share this with you as well. Okay, so the the Iowa Diabetes Prevention Plan, the meat of this presentation. I need to say that I was not here during that action plan. It was in May, and I started in June in this position, so bear with me. I caught this. I hit the ground running, but I also picked up a lot of this as I'm continuing to learn in this position. So this is a timeline of how things have been going. You can see right now we're kicking this plan off. And then throughout the next 2 years, it's a short-term 2-year plan, the kind of what we want to do there. Meetings with groups, leads, and stakeholders is something that I'm really passionate about. I don't want to just hang this plan on a shelf. Katie expressed the same feelings with the strategic plan. So I will have a call to action on everyone involved, as well as stakeholders that were there that day. But for anybody that wants to be a part of this action plan, I have information here in the presentation for that. Okay. So in the works, pillar lead meetings, I would like to call the stakeholders back and anybody else that is willing to participate in the pillar, an additional pillar meeting, so we can continue to focus conversation on what we're going to do now with the action steps that came out of the plan. The overall objective of the plan is to decrease the new cases of diabetes among Iowans with prediabetes and those at highest risk. So by increasing enrollment and completion of the CDC recognized diabetes prevention programs. So the 4 pillars are awareness, availability, screening, testing, and referral, and coverage. In support of the objective, these are the foundation and why they're the pillars. They hold up the plan. The action plan is a short-term plan, like I stated, but it should have a big payoff for our state in the end. Pillar 1 is awareness. The CDC estimates that 84.1 million people in America have prediabetes, which is a condition that puts them at risk of developing type 2 diabetes. Of those people, 9 out of 10 of them don't know they have it. So as we stated, 7.8% of people have confirmed that they have prediabetes or at a high risk in Iowa, and the other group don't know or haven't talked to their physician. So that's one thing. One thing we'll speak on is really increasing the screening, testing, and referral rates. That's huge. So for pillar 1 is awareness. Awareness of prediabetes and the effectiveness of the CDC recognized diabetes prevention programs. Within this pillar, we have 2 goals. A short-term and a long-term goal. The short term is by November 2018, so next year at this time, we would like to increase the number from 7.8% of people that know they have prediabetes to 15. And then the long term is to increase it from 15 to 20. I think those are realistic goals. Ideally, we would want everybody in Iowa to know that they have prediabetes, but I think in a short 2-year plan, I think that's an excellent goal, especially if we did get up to 20%. The action steps of Pillar 1 are here, and I've just outlined a couple of them. So identify sectors of the population that have little to no awareness, develop a media campaign to include social media, and the last one there listed that came out of the group was to explore the idea of a celebrity champion. So if anybody knows Mark Wahlberg, or you got a celebrity in your family, raise your hand or talk to me later. Moving on here, these are the stakeholders that participated in that pillar conversation. These are in alphabetical order, so not in an order of importance. So, Pillar 2, currently thousands of sites deliver the national DPP across the United States. These include in-person and online options, as well as programs that are a combination of both. The growing demand of diabetes prevention programs with or pending CDC recognition needs to be addressed to ensure the program availability meets the program demand. This requires building an effectively trained workforce to implement the diabetes prevention program and ensure program quality and standardized reporting. So the long-term priority of Pillar 2, availability, is to create an infrastructure network of all existing diabetes prevention program sites to maximize coordination, availability, and participation in DPPs and the CDC recognition programs. So what this kind of means in a roundabout way is, along with other things, we want to create a website where all the resources for the state of Iowa are in one place, so we can we can skip the running around, and we're going to be sharing information, as well as just developing a system of communication that everyone can attend to. Oh, and one thing I forgot to mention. Let me go back, sorry. There are 4 pillar leads. I skipped over this. There are 4 pillar leads, and they volunteered. There's a diabetes prevention team in Iowa, and four people on that team have volunteered to be leads or co-leads in that plan. And I wanted to recognize, and they don't necessarily need to stand up, but I wanted to recognize those people because they've volunteered and they've taken on a big role that is important. And if it's not necessarily in their work plan directly, but in a roundabout way, they work on those things. So Carol Hibbs from Marshalltown is the lead for awareness. So Carol's over here. Thank you, Carol. And now I'm going to move forward. You don't have to clap for me, but I'm the lead for this one. All right. Moving forward, action steps. These are the stakeholders that provided conversation for that breakout meeting. All right, so real quick, and I'm just going to introduce it, and then I'm going to keep going. So there's some note cards on your table, in the middle of your table, hopefully. And I would like it if you took some time, maybe even just the rest of the day, to write down up to three things you think that are very important to have on the website. One thing, and I didn't mention at the beginning, this plan, I didn't write this plan. This came out of the stakeholder engagement meeting. So all of you, or many of you that were there, helped to write this plan. So, and I want to continue, as I moderate the action plan, sort of, or facilitate it for the state, I want to make sure that you know that this is a plan that you all helped to develop. So, and that's why I wanted to bring this up too, because I wanted your input on the website and what you think is important. I mean, we kind of have a gist of it, but I also really want to hear what you have to say. So as we continue out the rest of the day, they don't have to be done at the end of this. Pillar 3 is screening, testing, and referral. Healthcare providers and delivery systems are overwhelmed by the growing number of patients with diabetes. Tools are available to help providers screen, test, and refer patients to diabetes prevention programs and that have a strong evidence to prevent their progression to type 2 diabetes. Referring patients to the NDPP can help meet regulatory, state licensing, and board recertification requirements. The recognition requirements allow providers to confidently refer their patients from the clinic to the programs. So for this pillar, the lead is Katie Reese, and you all know Katie. So thank you, Katie, for volunteering to be the lead for this pillar. The short-term priority is by November 2018, we would like to create a pilot specific modifiable template for screening, testing, and referring for a variety of providers and settings. And then in the long-term priority, at the end of this program, at the end of this action plan, we want to identify populations that are within the state where new protocols and guidelines can be disseminated and implemented. So I've circled 3 here, and these are not in an order by any means of lists of importance. So identify and evaluate existing protocols for STR to establish consistent guidelines for providers and settings, and develop new protocols for providers and settings. And if you went out to the CDC prevention website, they do have a few documents on things providers can do and send out to their patients if they recognize in the system, the health record system, that they might be at risk or they might have prediabetes. So they have emails, and then they also have flow charts on communication with someone who has prediabetes or is showing symptoms or risk factors. The pillar stakeholders that participated in this one is a larger group. Those are them. And for pillar 4, this is the last pillar. This is coverage. Prediabetes and type 2 diabetes are a growing concern in America's workforce. These conditions affect the health and quality of life to millions of United States adults and cost employers and insurers billions of dollars in lost productivity and medical expenses. Evidence shows that diabetes prevention programs can cut the person's risk of developing type 2 diabetes in half and reduce their risk of other serious health conditions. Obtaining insurance coverage for the NDPP for public and private employees as well as Medicaid beneficiaries is a critical driver to scaling and sustaining the program. And Medicare will be offering coverage for DPPs in Iowa across the nation, starting in January. And several other states have passed legislation to offer it as covered by Medicaid. So for this pillar, Amy Bowles is and we all know Amy, is the lead there. So thank you, Amy. Yes. The short-term priority is by November 2018, we want to develop a matrix of coverage options for the CDC recognized programs based on the payer type, and by November 2019, implement diabetes prevention program coverage with at least one besides Medicare. At least one. That sounded bad. We're thankful for Medicare, but another one. All right. So these are 3 I outlined there. Identify additional stakeholders to prevent and coverage in a coverage task force. Conduct a coverage meeting to create a priority section for matrix customize for different payers and different landscapes, and identify common themes within the regions. This is a little bit of a smaller group. So with the pillar group meetings, I do just want to stress that over the next few months, we need to regroup our efforts so we don't just hang this plan up. These meetings will be held at the Iowa Department of Public Health, and I just want to say that we can't be stagnant with this growing problem. So while those stakeholders participated in and kind of rose their hand and said, we want to work on this, this action plan is open up to anyone. So you can contact a lead, or you can contact me, and we can get you into a group that you think that you have a level of expertise in, or you want to have a say in. We want your input. So one thing, there are hard copies of the action plan over at that IDPH table, the resource table. So you can have that as hard copy. It is online now. It's been through the ringer and edited and reviewed. So it's online on our IDPH site, the diabetes sub-site. And I'll just leave you with this. Help us keep the momentum pushing forward as we continue collaborating on our statewide efforts of decreasing type 2 diabetes incidence rate. And that's my information. I flew through it, so if you need the PowerPoints or anything else, you have that again. And I'm going to introduce, or I'm going to have Susan come up from the NACD, and she is going to talk to you about things happening nationwide.
Hi, everybody. It's great to be here in Iowa. I was here in May for that engagement meeting. I was happy to be here then, and I'm very happy to be here now. One of the reasons I'm happy to be here is the warmth that Iowa brings. This is always meet great people in Iowa, and I get to visit my good friend Shelley Fulcher over there, who I've known for 30 years. So this is a delight to be here today. What I'm going to do is talk to you a little bit about the organization that I'm with, the National Association of Chronic Disease Directors. And then I'm going to tell you what's happening around the DPP at a national level, sort of some aggregate information. And then I'm going to let you know what's happening in some other states. Because this is truly a movement that is catching on, and we hope like wildfire. I shouldn't say that because I'm from California. Across the nation. And so it's an exciting time, but it's also an urgent time. As Andrew said, you know, we've got a huge problem on our hands, and we really got to dig in together and figure out a coordinated way to attack the issues so that we can make a big difference. And also get to some opportunities for Iowa. So let's start with the organization that I work for. We're a very serious organization, but I thought instead of words, you'd want to see us at our best. So these are a few people from our headquarters. We're based in Atlanta, Georgia, and we are hand in hand with the CDC, and so that's why we're based in Atlanta. Our executive director is the P in a pod in the back, John Robichur, a great guy. And we have about 25 people on our staff based at Atlanta, and they're mostly administrative to keep the organization running. Then we have about 45 consultants across the country, and I'm one of those consultants. I'm based in California, and as Andrew said, I used to work for the California Department of Public Health in the diabetes area. And the association itself works on more than diabetes. Diabetes is the largest initiative that we have, but we certainly work in lots of other areas. I think we have about 14 initiatives in total, and they cover different disease states, different chronic diseases, as well as some other areas like health equity or disabilities. So we're working on chronic disease prevention and control from many different angles. So we were founded in 1988 in partnership with CDC to strengthen state-based leadership and expertise in chronic disease prevention and control. We have over 6,000 members, and as I said, we're based in Atlanta. We are member-driven. I think that's important to know. So we really feel that we serve our members, and our members are the State Health Department here in Iowa and their partners, so we feel that you're all of our constituents here. And that's what we're really focused on. And it's simply put, we're trying to help state health departments succeed in their CDC-funded work. So that's a big, large umbrella, but that's what we're really trying to do. So what have we done in the area of the national DPP? And we've been in this game for a long, long time, since the study came out that proved that you could prevent type 2 diabetes. So we've been at it for about 10 years, and CDC's been good to us and had us lead different efforts across the country, sort of pilot programs, before the scale out and the national scale up of the national DPP across the country. So one of the things that we do are we help states to host these state engagement meetings like we had in Iowa in May. And we do a lot of planning for months ahead of time. We have a team assigned to that. We work with the state, and we execute the event. And then we also have a liaison assigned to each state that we work with, and I'm your liaison here in Iowa. We also bring national partners to the table. So we try to make really good connections. As you all know, our work is difficult as individuals. It can sometimes be a little bit easier if we band together and we form really strategic partners. So what we try to do is bring some of that influence from a national perspective. And so we have partnered with organizations like Levitt Partners, and you'll have a presentation from Rebecca this afternoon from Levitt Partners. They're a healthcare intelligence agency out of Utah. We've worked closely with them for a number of years. The American Medical Association, we have contracts with them to help states to bring connections so that they're working with their medical societies and taking advantage of those opportunities. We also work closely with the AADE and other organizations related to diabetes, and any organization really that is going to help us in this effort to scale and sustain the National Diabetes Prevention Program. Then I've got these numbers in parentheses here that you see. Those are really codes for CDC grants, and so you may or may not recognize those, but CDC's invested a lot of money in the National DPP in different ways, in the form of different grants, and they fund all states and territories for some level of funding, and then there are other opportunities for states to apply for additional funds. So they've got one, 1705, that's just starting out for the DPP in rural counties. The 618 is a high burden health conditions grant that is about 10 states have that grant. Some are focused on diabetes and others are not. And then we have the Medicaid National DPP Demonstration Project, and this is something that NACDD oversees for the nation, and we'll get into that a little bit later too. So this shows you the states that we visited. So we have the privilege of going across the country and trying to scale up the national DPP, and the blue states are all the folks that we visited, and the green states are all the ones we're visiting this year. So we've still got some work to do, but we're making good progress. And like I said before, we really help kind of host these meetings as a launching pad for scaling up the national DPP in different states. And so certainly the meeting is important, but what's really important is what happens after the meeting, of course. Andrew talked about these pillars, and this is just a way to break down the information. The national DPP itself, CDC sees that as sort of an umbrella over lots of different areas. And we've broken them down to these segments to make it easier to understand. And then the core of it is the lifestyle change program. So what's happening at a national level? Availability, you can see here the numbers. It's hard to see for me to see, but in 2013 we had 480 people or organizations delivering the DPP, and now we have over 1,000. We have 1,500, and these are all CDC stats, and they change frequently. So they're the latest ones I could get. They were delivered in Wisconsin last month, so they're pretty recent. And I wanted to talk just a little bit about the CDC's Diabetes Prevention Recognition Program. The national DPP itself, the curriculum, is not CDC. CDC didn't develop it. It was developed out of research studies, and lots of different organizations develop it. But they've really adopted it, and they've invested a lot of time and effort and funding to go towards it. And what they really want to make sure of are these programs are delivered in a quality manner. That they meet the standards for quality. Things are updated regularly. They have an online registry. So this is a way for them to ensure quality delivery. It's also very important as we move forward, and there are more organizations starting to cover this program because they're going to want ensured quality as well. So some of the requirements are going to be that you must be a recognized program to get reimbursement through Medicaid or Medicare, so that's why it's important to raise the issue. Enrollment, of course, has gone up as well. So, we started out with about 27,000 in 2015 and are now up to about 152,000. Good numbers, but when you look at the population of the United States, it's certainly not enough. And this is a slide that goes out of date immediately, and this is the information that everybody wants to know. So who's covering the national DPP and the Lifestyle Change Program? So there's lots of different commercial payers out there that are covering the program, but no one at this point is blanketing that coverage for all of its members. So it's parts of their membership, parts of the population, and maybe even one state or another, but it's not a blanket across the United States yet. So that's why it's difficult to say, oh yeah, this group is covering it and that group is covering it. It's in pockets, but it is building all the time. And lots of states have been able to secure coverage for public employees. So I think there's 12 states there, and some have some big populations, California and Texas being some of those states. So there's quite a number of public employees that are covered at this point. And they're still rolling them out, so even though they offer the benefit, that doesn't mean all the folks are scrambling to get into this program. As everyone has said before, recruitment is an issue. And then Medicaid, we're making some big strides lately. Minnesota and Montana were the first, but New Jersey and California have signed on. And I just attended a meeting in California earlier this week where they've created a small coalition to start to figure out all the details necessary to roll that out with a population the size of California, and a requirement for Medicaid that everything has to be delivered in at least 11 languages. So this is going to be very interesting, and hopefully it will serve the other states as well. So Medicare coverage is coming. The final review, the final rule came out in 2016, and then another second final rule was issued just this month. And so it's over 1,000 pages. I'm sure all of you have read it. There is a summary that's about 4 pages long, thankfully, and there will be lots of information coming out to kind of make it easier for us all to understand. So look for that. And services are to begin, I believe, in April 2018. So this is a program that we at the National Association of Chronic Disease Directors oversee. And you'll hear a little bit more about it later today around the coverage toolkit, so I won't really go into that. And then across the country, really what is happening? And I put partners, partners, partners. We've heard that word a lot today, but it is true. When we look at all the data that we collect at how the progress is going across the nation, rolling out the national DPP, folks are able to achieve so much more when they coordinate and collaborate together. So Iowa is so strong because they have their strategic plan. You had that even before we arrived in May, and now you've got a very specific action plan for diabetes prevention. So you're in a very strong place. And what we've learned by having these plans and the opportunities for people to come together and really action plan together is that invigorates relationships and creates new ones that are important. And sometimes those relationships with this particular public-private entity or program is critical. We need to deal out with partners that maybe we don't normally deal with so we can make things bigger and better for the rest of us. You've got a completed action plan, which is fantastic. I will say that in some states it took over 2 years to actually complete the plan because we are working in government and for lots of other reasons. Iowa did it in a flash when you really look at it. So it's really, really great that you've been able to complete that plan, and I applaud you for that. And then the work itself, the implementation of the plans is all over the map because we've been doing this since about 2012. So what's the typical role of state health departments in this work? They often work as a convener to provide structure and support. In other states too, we have lots of volunteers, some willing to lead and some willing to collaborate. But the state really does serve to keep things moving and to help track progress, which is difficult. So I was very excited to see that stoplight, that technique. I thought that was pretty cool, took a picture of it. So that's really great because it helps people know you're making progress. And in this work, sometimes we need to just stop and say, let's celebrate, we're doing our best and we're making progress. The state also usually works as a facilitator. And this is, again, an important role. Even if others are leading and willing to, we all know that everybody's busy doing their own job, so this sometimes is an extra burden on them. And so the state sometimes tries to make it as easy as possible for the work to move forward. And lead and collaborate in pillar groups, works groups themselves. You saw that Andrew's going to be leading a work group, and that's common in other states as well. Some states have larger staff in the State Department, and so they're able to have 4 different people assigned to different work groups. So it just is different in different states. So across the country, too, the state challenge, states have to kind of start from where they are, and they're all in different places. So states that have few lifestyle change programs, some states are just getting started. Some states have, 3 or 4 in their entire state. Others have hundreds. So it's all over the map. So everyone has to kind of start from where they are. But if they have few programs, then they have to focus on getting coaches trained and getting new programs established and providing support for existing programs. They also have to think about awareness and coverage and screening, testing, and referral. So those states that have maybe lots of programs or some programs, like Iowa, they might be able to focus a little bit more on recruitment and retention because we know those are big barriers. They might be able to focus more efforts in rural areas and in priority populations. They still focus on coverage and screening, testing, and referral. And awareness never goes away. There's always folks that need to be more aware of this program so that we build sort of a culture around diabetes prevention and the National Diabetes Prevention Program. So now I'm going to turn to some examples from other states and just give you the secret sauce for success for some of the states that I've worked with. Cassandra? Where's Cassandra? So I worked with Cassandra. I worked with Cassandra when she was in Nebraska, and she was brand new, and she took the ball and ran with it. And she had good support from her team at the health department, but also she had very wonderful partners who were willing to lead and collaborate in kind of growing the work in Nebraska. And what they did is they looked, they had their state engagement meeting, they looked at all the information that came out of it, and they kept it simple. And they simplified all those messages for the masses. And so they tried to keep everything very simple, take a very methodical approach, and also they focused on all 4 pillars, but they picked 2 to really kind of do first, thinking that those other 2 would follow. So it was very strategic what they did, and they were able to keep the ball moving forward. So I appreciate the work they've done in Nebraska. I've also worked a lot with Washington, which is very complex in different ways. They had 4 pillars, but they focused all of their pillars on coverage of different ways. Commercial, there was a pillar group on commercial coverage, there was one on private coverage, there was one for the underserved, and so their state engagement meeting looked a little different, and also their outcomes looked a little different. But in fact, what happens after that meeting is they need to do the same kind of thing. They need to have these groups come together, figure out what they're going to do, make a plan, and just start ticking it off. And in California, I chose this photograph because it's beautiful, but it also shows a lot of people, and boy, do we have a lot of people. So the state health department, they had their state engagement meeting, I think, 3 years ago, well attended, lots of players who couldn't get in the door because we just didn't have the room for them. And what happened at that meeting is not an immediate reaction to the information, but some of the folks that came represented organizations that could really make things happen. And that is what has happened. So in the short term, what the state did is they organized their work groups around pillars, and they moved forward, and lots of different things were happening in lots of different places. But at the same time, some of the larger, more powerful organizations like the Public Health Advocates nonprofit organization started thinking about what they could do at a statewide level. And they started to build a foundation for really making the argument of why aren't we paying attention to prediabetes, and they're very, very good at it. So they did that, and they also suggested that this should be a covered benefit in Medicaid. So they were instrumental in making that happen. So the state was there to kind of lead them through the early stages of it and are there to carry it out with them. But really it's this outside group, the public health advocates, that is making that happen. And now again, they're building a different coalition to make it happen, make all the details happen to make that coverage happen in in California, sorry. So in Iowa, I think you're in a very strong position. You know, you've got national support from the CDC, from our organization, and with Levitt Partners, this healthcare intelligence firm that I talked about. You've got momentum in other states. And we've got Medicare coming here, Medicaid in other states. We've got examples of how folks have achieved public employees and coverage for public employees and also commercial coverage. So there's a lot of momentum going around there. And there's tons of tools, resources, and models. And so, you know, it's almost at this point in the game, if you think about it, it's out there. So I know people like to develop tools, and certainly there are specific Iowa tools that you should develop probably for your population. But for lots of things like those very expensive ads that Andrew showed you, you don't want to waste your dollars there. That's already done at a national level for you. So again, you've completed your action plan. You've got strong partners and collaboration. You've got strong capacity, and you have the ability to move forward. So go forth and conquer. Thank you. Go ahead.
We received a couple of questions here through our text. So the first question, are there any DPPs focusing on incorporation of children? They mentioned that in Illinois, the sports participation forms have started with screening questions, and they're wondering if there's an opportunity to do such in Iowa.
Not that I'm aware of. The DPP, all the study, all the evidence is on adults, and so for the the pure DPP program, it is not really for children. But I know that in some states, what they've done is they've encouraged family members to come to the classes, and so that it gets to the family members that way. They also offer sometimes child care, and they might have some lessons for those children at that point. That's what I know.
All right, and a second question. So we know there's a fee to become a Medicare provider for DPP, and you must be fully recognized. That's a big cost that goes into that and a lot of paperwork. So what would you say to folks to tell them that it is worth it to do that to become a DPP provider?
Is this one? Just gonna use this one. It's worth it to become a DPP provider because there will be financial gains made from that. But however, if the resources in your facility are there, say you have a DSME site and you have educators currently doing the management education, it's really not that much of a transition to take those same educators, send them to the lifestyle training, lifestyle behavior training, and then implement a DPP as well. Because I think, ultimately we need to be able to provide programs, a multitude of programs, a multitude of things that people can participate in order for them to kind of see the light and take their own health care into their own hands, which is kind of what a lifestyle change program does. So in regards to, it costs a little bit of money to get started and a lot of planning. I think it's certainly worth it because the prediabetes and diabetes epidemic is just too profound right now to ignore. So.
And I'll just add to that a little bit too. We've seen some different models across the country, and some organizations that currently deliver the DPP will find it hard to make that jump from delivering the DPP lifestyle change program to billing and coding and all those administrative things. And so they have been encouraged to partner with an organization that are specializing in that rather than to take that on, so that they can concentrate on the things that they do best. Also, in some states, they have some organizations that will serve as sort of a hub, and that organization will get the license and do all the administrative work for several different other organizations. So there are some models out there that we could dig up for you if you like.